I use self, okay? Because obviously self, we don't destruct. Foreign material, we got to handle with, okay? By the way, this is all theoretical construct because, I mean, it's never really been proven, but there are pieces in this. So, for example, this reaction here drives a Th1 lymphocyte population, all right? T helper cell 1. What do they produce? What cytokines do they produce? IL-2, TNF-alpha, interferon gamma. Okay, so that's this, and as I showed you, you see increases in these chemokines in the sarcoid reaction. Okay. So here we then have the cytokine release and proliferation and activation of histiocytes into these granuloma formations. And this is essentially the story. So what's the difference between a chemokine and a cytokine? What do chemokines do? Chemokines recruit more cells. They are chemotactic factors. So IL-8 is a neutrophil chemotactic factor. Eotaxin is an eosinophil chemotactic factor. Rantes something is an eosinophil chemotactic factor. So these are substances or chemicals that attract more cells. So this is the basic inflammatory. This is the HLA, standing for leukocyte antigen. Something leukocyte. It's a compatible leukocyte antigen. Thanks. These are the names. And this is the receptor that is actually. Oops, I can't get it. It's actually on the antigen presenting cell. Okay, and this too is a factor in deciding self from non-self. And this is what this receptor reaction is really what starts the cascade, immunologic cascade, and the proliferation of the CD4 cells, and then this Th1 cytokine proliferation. So enough immunology here. Organ involvement, pretty much everything. Obviously, respiratory tract, lymph nodes, big. Sinonasal, awful disease. Well, you get granulomatous disease in your nose and sinus. There's a number of patients there. I mean, why? Because they're constantly obstructed, they're infected, they have anosmia, they can't taste, they can't smell, they can't, breathe through the nose. It really is, it doesn't really respond well to intranasal steroids, and even oral steroids. Once they get that chronic remodeling of the mucosa, they really are pretty miserable. So ocular involvement, we'll talk about in a second. There's a couple of things. Salivary gland, there is a popular scan. It's called the PANDA scan. You ever see it? I'll show you the PANDA scan. Gallium scan. Skin, yes, bad disease in the skin usually portends a very bad prognosis. Cardiac, bad stuff. You got to do MRI to prove that. Bone and joint, not that common. Bone and joint almost always goes with skin. So if you've got, if you have, let's say, an arthritis without skin involvement, the likelihood is it's not sarcoid. Look for something else. The two just go hand in hand. And the bone involvement is a very, very specific involvement, and you can diagnose it like that on an X-ray of the hands. I'll show you in a second. Rare nervous system, most common nervous system is cranial nerve involved, facial nerve involved. But you can have all kinds of, I'll show you a case of CNS sarcoid, horrible disease, horrible to treat, this is chronic, long-term, and more recently treated with some of the TNF-alpha blockers, antagonists. And then liver, spleen, kidney. Kidney rarely you see kidney. Liver is commonly involved. We usually almost never see chronic liver insufficiency as a result of sarcoid. Just not that much involved. And spleen is big. What's important about the spleen? It's sometimes very big, and sometimes bigger than very big. And actually, there are a number of cases in the literature of splenic rupture from sarcoid. Catastrophic disease, just from huge spleen. And in cases of a large spleen, especially depressing stomach, early satiety, and just a lot of fullness and it's growing, splenectomy is a true consideration. Although obviously treated with steroids, but they may not respond. Okay, so let's talk about the lungs. I got to keep careful of time because there's an awful lot of material here. Okay, occurs sometime in essentially all patients. 90% is the sole manifestation of sarcoid. Classic symptoms: shortness of breath, cough, chest pain. Now, here's an important thing you see here: hyperreactivity up to 20%. Several months ago, we talked about bronchoprovocation testing, methacholine challenge. And we said that a methacholine challenge is a test that looks for twitchy airways, essentially reactive airways. If you and I did a methacholine challenge test, our airways would go a little bit, wouldn't really respond very much. I mean, everybody has cholinergic innervation of their bronchial tubes, so there is always some cholinergic tone, which is, by the way, if you and I took an inhaled bronchodilator, we bronchodilate. That's why. But it's minimal. Okay. If you then give a cholinergic agonist, you get a little bit more constriction in normal people. If the airways are abnormal, this cholinergic agonist causes severe constriction. And asthma is the prototype. This is the classic. You don't have bronchial hyperresponsiveness, you probably don't have asthma. And the problem is that while it's highly, well, here's another thing, it's highly sensitive in asthma, specificity is not great. One of the reasons specificity is not great is right here, that even diseases, probably due to granulomatous inflammation of the airways, the test can be positive. Other positive tests can be seen. Larger rhinitis, you can see it. Remember I told you after a viral URI, you can see you get twitchy airways. What else? Sjogren's syndrome, you can see it, so forth. Okay, so interstitial lung disease involving alveoli, yes, bronchioles, sorry. And as we talked about, this is a T-cell alveolitis, CD4 cell. Remember, that's the imbalance there, greater than 4 to 1. Bronchial lung biopsies, diagnostic and greater than 80%, transbronchial biopsies. And it really depends upon the stage of sarcoid. Stage 1, you don't see much lung involvement. The transbronchial biopsies are going to be maybe in the 60-70% range. Once you get interstitial disease, a good lung biopsy, it's going to be up in the 80-90% range. So here they are, the discrete, compact, well-defined epithelioi, granulomatous, the swirls. You recognize these all over the place. In the lung, 75% are within the connective tissue sheath, the bronchioles, subpleural, perilobular spaces, and lymphatic areas. Okay, not usually in the sheath of the bronchiole, but usually not involving the bronchi themselves. Usually it's more the interstitial. So what else are we going to see here? I guess this is just pointing to giant cell. I'm not so sure why I did this. Okay, so here's the radiologic staging. There is such a thing as stage 0 normal chest x-ray. How the heck do you get that? Well, they refer from skin clinic, usually. Rarely, maybe refer from the GI clinic. They were doing a liver biopsy for something else and they found granulomas. But it's very, very uncommon. Prognosis usually, I mean, it says excellent here, but at least from the lung point of view. Okay, bilateral hilar adenopathy, paratracheal adenopathy, excellent. And we'll talk about that in a second. Then you got stage 2, which is the adenopathy plus the interstitial, and this is the bad stuff. You get a patient with stage 4 sarcoidosis, often the prognosis is really not good. Here's just for fun. Here's a chest radiographic in this Blue Journal study in 2001. Chest radiograph is at the time of initial diagnosis. 3 countries, and they're fairly comparable. But you can see here that the most common of all is just stage 1. Hilar mediastinal adenopathy, and that's it. Okay, so here's what it looks like. Here's a little clinical clue, okay, that you should recognize. You notice, number 1, how relatively symmetrical this is. That's what sarcoid usually looks like. This guy doesn't have an impressive right paratracheal, but I'll bet you on CT he would show it. But that would be the classic. We call the 1, 2, 3. Right paratracheal, right hilar, left hilar. So they should be fairly symmetrical. The other thing is here, you see that there's no space between the nodes and the mediastinum here? I mean, this is all taken up. That's the way it should be. You see a space in here. You see a space in through here. Lymphoma. Yeah, I would consider it possible malignancy, not sarcoidosis. Is that a firm absolute? No. But just a little bing suspicion that it should look like this. Oops. Usually no respiratory symptoms. And here, look at this, 60 up to 80% of people, you go through this stage, don't even know it. You're picked up often just by a positive chest X-ray. Okay, so here's the lymph nodes, bilateral, usually symmetric, 85% of the time. 5% unilateral. Now, why am I making such an important point of this? If you see a patient coming in, right age group, 20 to 40, give or take a few years, bilateral symmetrical hilar adenopathy, no symptoms, pat them on the back, tell them they likely have sarcoidosis, they don't have metastatic renal carcinoma when they're presenting as bilateral hilar adenopathy, they don't probably have lymphoma, no B symptoms, no symptoms at all, but you're going to watch them. You're going to follow them. You're not going to do a biopsy. I would almost never do a biopsy. This was actually studied years ago. Article in Annals of Internal Medicine. Winterbauer published this years ago. He showed prospectively that you can watch these people, they do well, and if they have any of the other atypical things, then you biopsy. But if they've got this typical, continue, so you see maybe in 3 months just to make sure, get another x-ray, everything's fine, maybe get some PFTs, check their eyeballs and all that other stuff that you're going to do anyway with sarcoid, but you don't have to do that. Now, let's say it's unilateral hilar adenopathy. No way. You're going to make sure that you're going to pursue this diagnosis. Why? Because you've got only 1 out of 20 chances that you're going to be right on this, or, you know, if only 5% of the sarcoids have. So it's just such an atypical thing that you're just not going to do that. What if you saw mediastinal lymph adenopathy? No hilar adenopathy. No way. Now, not that you have to biopsy every mediastinal adenopathy that you see. You will. But the point of the matter is, I'm not going to call this sarcoid. It's just too uncommon. Lymph node calcification, what if you saw it? Yeah, what does calcification mean? Chronicity. It's been there a long time. Doesn't say anything. Positive, negative, doesn't mean anything at all. And this eggshell, I don't know if you've ever seen an eggshell calcification. I've got a couple upstairs, in the office upstairs that I brought in. It's just a lymph node where the center's empty and you just see a rim of calcium. It looks like an eggshell. No big deal. It doesn't mean anything. Sarcoid can do it. Silicosis is the typical classic eggshell calcification, but it just means calcified nodes that have sort of shelled out. Doesn't mean anything. Now, if you see lymphadenopathy anywhere else, not the typical violent color, forget it. You've got to go after the biopsy. One of the places that it shouldn't be, anterior mediastinum. I didn't say anything about anterior mediastinum. So if you see anterior mediastinal lymphadenopathy, just very, could it be sarcoid? Yeah. Did you ever see a case? Yeah, I did, but it was just not typical. So anterior mediastinal adenopathy, or isolated middle mediastinal adenopathy, you go after that diagnosis. It's not sarcoid. Okay. Can you get spontaneous remission? Absolutely. This guy is 2 years later. You still see a little bit of actually, this has been described ghost shadows of sarcoid. I don't know what it means, but I remember reading about that, ghost shadows. And it looks like this guy is not exactly spontaneously remission. Oh, sorry. Well done. All right. Stage 2, about 25% of patients, they do sometimes have symptoms. Fever, weight loss, not very common, but happens. So, you know, it can, no question, it could still be sarcoid. Shortness of breath, yes. Why? Because the lungs are involved now. You still get a pretty good, healthy remission, but not as good as stage 1 disease. So, you know, you follow them along and you see what's going to happen. Stage 3, a smaller percentage of patients present like this. The question, actually, you asked an interesting one. Did this patient here What if you looked at him 2 years ago, 3 years ago? Would he have had the lymph nodes? I mean, nobody really knows, because that's, but you can evolve into a stage 3 from stage 1. So I know it happens. But look at the spontaneous remission rate. You present with this, the likelihood that you're going to get better is not very good, and obviously the stage 4 worse. So here we go, stage 1, stage 4. Stage 4 is predominantly an upper lung zone disease as opposed to a lower lung zone disease. Why is that important? Well, there are certain diseases like IPF, asbestosis, that are more lower lungs. Is this an absolute? No. But if you saw a picture like this in a patient who just comes into your office, have you been sick before? No. I look at this and say, wonder whether this guy had sarcoidosis years ago, and now we're presenting for stage 4. Is it possible that he could not have had a diagnosis of stage 1, 2, or 3? Yeah, sometimes just people just show up like this. Okay, and this is the stage 4. Now this is a bad, so what was this? Yeah, stage 4, bad, because there you get a lot of cystic changes, destructive changes, and look at a CT scan. I think I'll show you these holes in the lung from lung destruction. This is the one that has the higher mortality rate, chronic respiratory impairment. These are people who have really horrible lung function studies, restricted disease, low diffusing capacity, may even have obstructive lung disease. Remember, anytime you get scarring in the lungs, those scars, like every scar everywhere else in the body, they begin to shrink. And as they shrink, they are stretching the airways that are sort of surrounding them. So you get bronchiectasis. You get bronchiectasis in old TB, an old sarcoid, an old anything in the lungs, because as those scars form, the airways begin to pucker and stretch and so forth. And that can obviously cause recurrent respiratory infections and so forth. I talked about the high mortality right here. Here's the CT scan I pulled out. That's sarcoid, believe it or not. Look at all that destructive changes. More sarcoid, high resolution CT. Sometimes they're larger air spaces. These are the guys that get infected with aspergillus. Why? So ubiquitous fungus. It's all over the place. Right here. Yeah, there it is right there. And if you breathe it in, you get rid of it fast. If you're allergic and you become sensitized, you then develop either asthma or allergic bronchopulmonary aspergillosis. If you have a warm, wet, comfortable place in the lungs, right there, and this aspergillus gets in there, starts to grow and grow and grow, and that's probably why you get aspergillomas. They're just a fungus ball. It's a benign thing. They may have a slight attachment to the bronchial wall, which is probably why they cause sometimes some big time bleeding, but they're not invasive at all. Not even semi-invasive. They just sit there, but they can cause bleeding. And that's why they sit there, because they have a nice, happy place to grow. Okay, we talked about the lymph glands. Not too many, only a third with palpable nodes. You may sometimes see axillary epitropial and inguinal. They're discrete, movable, non-tender. They don't ulcerate or anything like that. They're much more common to see with black. Laryngeal involvement. Hoarseness, stridor, epiglottis can be involved. As you see localized edema. This is a vocal cord that's involved. You biopsy this. What do you see? Non-caseally granuloma. Ocular involvement, chorioretinitis, vitreous opacities, and so forth. But here's the other biggie. Lacrimal gland can be enlarged. If you suspect sarcoid, obviously you would go to the lungs and the lymph nodes first, but you can actually do the lacrimal biopsy. It's an easy thing for the eye guys to do. You do a little punch biopsy, and you can make a diagnosis. So here's a lacrimal gland enlargement right there. You can see, and it's just big. So what else do we want to see? Okay, cardiac, not common for some reason more in Japanese patients. The most common thing is ventricular arrhythmia. There have been sudden deaths, usually young black males. Heart block, supraventricular. The most common thing is arrhythmia, and particularly ventricular arrhythmia. In most papers say initial screening of EKG is recommended. I guess. I would think if you had advanced sarcoid, but I'm not so sure if you hyaluronopathy is the right do. Endomyocardial biopsy confirms the diagnosis. Okay, cutaneous erythema nodosum we talked about. You can see almost any kind of eruption of the skin. Nodules, papules, erythematous lesions, elevated lesions, plaques. And this lupus pernio, most commonly in black women, As I said, skin lesions often associated with bone and joint. You can actually see infiltration of prior scars of this. So here's the classic enodosa. One there, one there, one there, one there. They're usually tender. Okay, this is, here's lupus pernio, right there. It's usually around the nose, and usually in the creases in here, and it looks like little pearls, flat pearls along the nose. And that's lupus pernio. This is a woman with sarcoidosis also, and you could say lupus pernio. These are more sarcoid nodules here, but that's classically, you see it around the nose. Arthropathy we talked about, not that uncommon, can mimic rheumatoid arthritis. The bone involvement, as I said, uncommon in the absence of skin disease. Muscle involvement is common, weakness, generalized muscles. Here is the classic. You see bone cysts. See, this is a hole here. See this? Cyst, sarcoid. Bone cysts like that. Okay, and here's more bone cysts. But usually you can see them in the hand. Get a hand x-ray. Neurosarcoid, I talked about.